The classic picture would be a child that has so much discharge that the eyelids are glued shut in the morning. That might be what the parents are telling you about. And that's actually a pretty highly associated with bacterial conjunctivitis.
It's one of the most common calls you'll get and one of the fastest spread through a classroom. A pink eye shows up and suddenly the questions follow. Is it contagious? Do they need drops? When can they go back to school? Pink eye seems like a simple fix until it's not. From bacterial to viral to allergic, knowing what you're actually looking at can change everything. This is Charting Pediatrics. To discuss this important topic, we are joined by Becca Edwards Mayhew. She specializes in pediatric ophthalmology and adult strabismus here at Children's Hospital Colorado. She is also an assistant professor at the University of Colorado School of Medicine. Becca, welcome to the podcast.
Thank you so much for having me.
We are thrilled to have you. Let's start with a definition of pink eye, otherwise known as conjunctivitis. And let's focus on kids.
Okay. Well, to start, I think a little anatomy reminder is helpful. So the conjunctiva is the transparent vascular tissue. It's a mucous membrane that covers the underside of the eyelids and the white part of the eye. So everywhere other than the cornea. And it's really important for our tear film and for providing a barrier to infection and environmental exposures for our eyes. And it's also very frequently infected in kids for those reasons. It gets exposed to a lot of bacterial and viral pathogens, and kids touch their eyes, rub their eyes a lot. So that's why we see conjunctivitis, which is, an infection of that tissue very commonly in children.
So when a child with a pink eye or a red eye comes into a pediatrician's office, what kind of mental triage should they be going through?
Yeah, I think taking a really good history is going to be helpful, finding out, how long it's been going on for. Did it start in one or both eyes? What are the other symptoms the child's experiencing, such as upper respiratory infection symptoms? Are there sick contacts in the home or in the school or the daycare? And then finding out kind of what else is going on as far as the child's presentation. So are they having a lot of discharge? Are they having a lot of itching? Is their vision impacted? Is there swelling of the eyelids? Things like that will be very helpful in kind of starting to triage what's going on.
So Becca, after a pediatrician has gone through the initial mental triage on gathering, history and symptoms, how do you get them into a silo of bacterial versus viral versus allergic?
It's a great question. And there's been a lot of research to try to figure out what's the sign or the symptom that we can use. And unfortunately, there's not really one reliable sign or symptom that will tell us for sure whether something's bacterial or viral. I would say allergic maybe is the easiest one to kind of think about because you expect that to be more of a chronic picture with exacerbations, perhaps at certain times of the year. You expect them to have significant itching as the main symptom. And, they may have other allergic symptoms or other history of atopy. So I'd say that one's maybe the easiest to kind of think about for allergic. And then for bacterial versus viral, there's a few, different features that might point you in one direction more than the other. So bacterial is more common in children. It's about 70% of infectious conjunctivitis in kids. It tends to be unilateral or maybe bilaterally sequentially, so starting in one eye and then spreading to the other eye. The classic picture would be a child that has so much discharge that the eyelids are glued shut in the morning. That might be what the parents are telling you about. And that's actually a pretty highly associated with bacterial conjunctivitis. The other finding you may have would be, lots of mucoid discharge. Children may have other infections at the same time, like very commonly ear infection at the same time would make it, much more likely that this is a bacterial cause. Specifically, non-typable H flu is really common. And so those ear infection and the eye infection should be treated with antibiotics in that case. For viral, you might expect that it's more likely to be bilateral, more watery discharge. They may have sick contacts at the school or in the home where it kind of runs through the whole family. Viral also can be associated with preauricular lymphadenopathy, so feeling that lymph node there, and with pharyngitis, you might expect that to be related. So you would see that caused by adenovirus usually for kids.
So it sounds pretty easy when you say it just right now, and I love that. And then how good is like laterality or presence or absence of itching in getting you into one of those 3 silos of diagnostic criteria?
Like I said, there's not a single sign or symptom that's super reliable. So I think it's really about the whole picture, and you kind of have to put it together with your clinical history and what else the child is experiencing to try to understand which category you may be falling into. And I think, for this, most bacterial conjunctivitis does, resolve on its own even without antibiotics. So you do have some time to think about things and maybe make a change to your management if things aren't behaving the way you would expect them to, or things aren't responding to medications that you start.
So you just brought up a great point. And so there's obviously a branch point where you could either give antibiotics in terms of a topical drop, or you could do watchful waiting. So how did this all evolve, and what are your thoughts on it?
Well, I think with all kind of watchful waiting approaches, it's stemming from the fact that we realize we're probably way over treating kids with antibacterial medications, and they maybe not be benefiting kids, and maybe they're just promoting, resistance in the community. So trying to be good antibiotic stewards while at the same time balancing the family that's in front of you that took off work and took their kid out of school and really wants, some help with dealing with this problem. So trying to find a compromise that feels to the family and to the patient like we have a plan in place if things aren't getting better after a couple days, but trying to decrease the amount of antibiotics that we're using either in conjunctivitis that might be viral in etiology, or that maybe would resolve on its own, even if it's bacterial.
Is there any danger in terms of not treating say it is a real bacterial conjunctivitis? Is there any danger to not treating immediately and doing watchful waiting?
I think for a simple, otherwise healthy kid without risk factors, there's not a downside to wait a few days. About 60% of bacterial conjunctivitis is self-limited. So I think that it's reasonable. Now, if there's any risk factors that or make things a little bit more of a dangerous situation. So what I mean by that might be a neonate. Obviously, we're not going to do watchful waiting for a neonate that comes in with conjunctivitis. That's a very dangerous situation that might have vision or life-threatening consequences. So that's a totally different situation. Or a contact lens wearer is also in a different situation. Somebody who's immunosuppressed or somebody that had recent ocular surgery. Those are people that we're more concerned about, and that I wouldn't recommend watchful waiting in those cases. But I think for the average, otherwise healthy child that's coming into the office with pink eye, it would be reasonable to wait.
So you just mentioned the parent who's taken time off from work. They've come to see you in the office. They've got a kid with conjunctivitis. How do you get them to buy into watchful waiting?
I think it's really a conversation about shared decision making. And I think that many parents don't want to expose their children to antibiotics that they don't need, especially if they understand this could maybe make it harder to treat infections in the future for your child. So I think many parents understand that. And if they feel like you're on their team and that you're not just brushing them off and not giving them any options, then, about half the time they will wait and not need the antibiotics, not use them.
And then, Becca, I just want to clarify one thing you said earlier. You talked about conjunctivitis otitis syndrome. Mm-hmm. And in that case, you would use antibiotics. Although we do watchful waiting for otitis as well, is there a reason why you said that we would, in that case, use antibiotics?
Yeah, that's a great question. I think in that situation, if the child is febrile with otitis media and with conjunctivitis, then it's reasonable to do some antibiotics in that situation.
Is there any role for steroids?
So, not from the pediatrician, I would say. As an ophthalmologist, I see the really nasty outcomes with, inadvertent chronic steroid use around the eyes or in the eyes. Certainly, if we have an infectious etiology, we're not going to be starting steroids except in very particular situations. For example, in EKC, if the patient has subepithelial infiltrates, we sometimes will treat with a topical steroid in that case. But I would say in general, there's not a big role for steroids here. Allergic conjunctivitis will respond beautifully to steroids. They feel so much better, but definitely needs to be started in conjunction with an eye care provider of some kind who's going to be doing the follow-up, who's going to be able to check the eye pressure and sort of monitor the patient while they're on those medications.
And just to clarify, you just used the terminology, I believe, SKC?
EKC?
EKC. Mm-hmm. Can you clarify that for our listeners? Sorry.
Epidemic keratoconjunctivitis, which is that highly infectious form of viral conjunctivitis. That's all. It's caused by some particular subtypes of adenovirus, and it's really nasty. It's sort of an ophthalmologist's nightmare because the organism can live on plastic and metal for a month at a time. So it's incredibly infectious and incredibly hard to disinfect your slit lamp after you see a patient with that.
That's fascinating. I never actually thought about that. Is there any role for cultures or any kind of testing, rapid testing in these kids?
Definitely in patients where you might suspect gonorrheal or chlamydial conjunctivitis. Certainly there's a role for gram stain culture and or PCR testing. So I'm thinking about neonates and also for sexually active teenagers. You could think about those things. Classically, gonorrheal conjunctivitis is sort of this hyperacute, so much mucus discharge that you wipe it away, it immediately reaccumulates. And the thing that's scary for gonorrheal conjunctivitis is that it can cause corneal perforation in an otherwise a previously healthy cornea. So it makes us very nervous as ophthalmologists. Of course, for a neonate, we're concerned for systemic life-threatening consequences as well. So in those cases, getting a gram stain very quickly is very helpful to confirm the diagnosis. I would say in routine, the routine child that's walking into your office, I don't know that there's a huge role for culturing, especially if we're going to watchful wait and they're doing okay. I don't know that there's a big role for that in that situation.
And now for the big question that everybody is waiting for. How long are they contagious and how long do you have to stay out of daycare or school?
Yeah. So viral conjunctivitis, is contagious for 10 to 14 days. Really long time. And, there's different sort of recommendations based state to state and school to school for how long you have to stay out of school. I think it's reasonable to stay out for a whole 7 days after after the eye was red and watery, which is a really long time to ask people to adjust their childcare and their work and things. For bacterial, many schools will say you can come back after 24 hours after starting antibiotics, which might be a reason that family wants to start some drops rather than watchful wait, even though the transmission doesn't really change that much after starting antibiotics. So, depends on your school, depends on your location, what the rules are, but certainly this is a infectious for quite a long time, unfortunately.
So probably parents need to know not only the science from their pediatrician, but also what their school says, which may be different at times.
Yes, definitely.
I know I've had some fights with daycare myself about that.
Yes, I write a lot of school notes for this is not infectious conjunctivitis. Patient can return to school even though the eye is still red. So it's definitely, but on the school side, I understand the level of concern because this is such an easily spreadable problem.
Yeah, it's really hard to balance treatment versus the time that patients and families have to take off from work. Do you have a way that you address that? Or, would a mom say, I think you alluded to it, hey, just give me the drops. Kid goes back in 24 hours and all is good.
Yeah, I think that it's a really hard thing to navigate with families a lot of the time because it's just a really big deal to ask people to stay out of work for that long. But on the other hand, keeping your child home prevents all the other families in the school from being in the same situation. So we try to work with families to work with their employers to say, hey, no, they really do have to stay home with their child right now because of this. But it's a difficult situation for sure.
One of the things we all worry about is missing something. What are kind of the key red flags that all pediatricians should be constantly on guard for?
I think that, from an eye standpoint, the things that we're worried about is if the cornea is involved. So what would be the signs of that? Well, they would have more severe pain. The cornea is one of the most heavily innervated parts of the body. Anybody who's had a corneal abrasion can tell you how much that hurts. So more severe pain than you would see in just kind of an infection involving the conjunctiva alone. Very light sensitive, decreased vision. Of course, you can have a little bit of blurry vision with conjunctivitis because you have all this mucus or discharge everywhere, but corneal involvement would cause more of a profound decrease in vision. And then, of course, if you can see that the cornea looks hazy or it looks like there's an ulcer there or something like that, those would be things that would make us very concerned. Systemic things, if the child is systemically unwell, of course, there's lots of things that could be going on that would involve the eyes or present with, red eyes. So things like Kawasaki disease, things like COVID, measles, Stevens-Johnson syndrome. We see a lot of reactive infectious mucocutaneous eruption or RIME, which is mycoplasma induced sort of mucocutaneous response without the skin involvement like Stevens-Johnson. So any of those things, if the child is unwell and has other symptoms going on, then certainly that would be a red flag. And I think probably pediatricians are more keyed into those than we are as ophthalmologists sometimes with the lights off and not looking at the whole patient. And then another, very common thing that we see would be like preseptal and orbital cellulitis, which, you could have a reactive conjunctivitis as well. And so we wouldn't want to miss those things because obviously those have a different pathway that we go down.
When should a pediatrician consider getting an ophthalmology consult or sending them directly to your office?
Certainly those at-risk groups that we talked about before. So a neonate, a contact lens wearer, someone who's immunosuppressed, someone that you may suspect gonorrheal conjunctivitis or HSV conjunctivitis because they have vesicles on their face. People that aren't responding the way you expect to therapy, people that have really severe pain, decreased vision, any suspicion for corneal involvement should be sent to an eye care provider for an exam.
So in terms of other things that we don't want to miss, I know there's some other mimickers in terms of the red eye, blepharokeratitis. What can you tell us about those entities?
Yeah. So, we touched on allergic conjunctivitis already, very common in kids. There's a few different, flavors related to that. So vernal keratoconjunctivitis is a, very severe form of allergic conjunctivitis. Atopic keratoconjunctivitis is another one. One that I want to kind of get on my soapbox about a little bit is called blepharokeratoconjunctivitis, and this is really a spectrum of things. Probably most listeners will say, I've never heard of that. But what it encompasses, you've seen many, many times, which is kids with blepharitis or eyelid inflammation. They get recurrent styes or hordeola or chalasia. They often have eye redness associated with that. Tearing, photophobia. And what I want to reach your audience about is that many of these children can have corneal involvement with that too. So we think that the staph aureus bacteria that lives normally on our skin is causing sort of a hypersensitivity in some people. And so we can see that involve the cornea as well, which causes corneal scarring. It can cause irregular astigmatism and amblyopia. And so we often have kids who've been treated many times for pink eye because this condition is chronic but has flare-ups where things get episodically worse. So kids get treated multiple times for pink eye, and by the time they finally make it to the ophthalmologist, they already have scarring and poor vision outcomes from that. So something I want people to be aware of, if you keep seeing a child with recurrent red eyes, recurrent conjunctivitis, don't just keep treating it with polytrim or erythromycin. Get another look at the eyes.
Is there a certain number of times that would trigger a referral to ophtho for, sometimes it's hard to weed it out. The kids in daycare, the kids in school.
Sure.
I mean, how do you know when it's more recurrent that you worry about severity?
Yeah, I don't know that I would put a number on it, but if the child really doesn't seem to ever fully recover, like it gets better, but it's never all the way, the symptoms are never fully gone, then that might be a reason that, hey, we really have allergic conjunctivitis or we really have blepharokeratoconjunctivitis that we're not actually adequately treating. So I think that could be a clue. If it's very classic and it resolves after a short amount of time and everybody in the family got it and got better too, even if that happens multiple times, because our kids bring home such wonderful things from daycare for us to enjoy. That's not as concerning to me, but, for just based on the number of times. But I think it's that resolution in between that really is important.
And that's a perfect differentiator. I love that. Are there any references that you utilize or would recommend utilization on treatment for bacterial versus viral versus allergic conjunctivitis?
I think there's a really nice summary statement from the AAFP that has like a really nice flow chart of kind of what to do when. So I think that's a useful thing. I mean, we're not using antibiotic sensitivities or things like that to guide our treatment. So, the most common things that people would use for bacterial would be and here in the States would be polytrim drops or erythromycin ointment. I think the studies have shown they're equivalent as far as their success rate. One's an ointment, one's a drop. So ask family what they think's easier to get into their thrashing toddler. For fluoroquinolone drops, I don't think those are necessary initially unless maybe you have a contact lens wearer or something like that.
That's great. So just to summarize, what I've heard you say is that conjunctivitis really is a clinical diagnosis. And with good physical exam skills and history skills, we can sort of figure out if it's viral, bacterial, or allergic. We've also talked about some red flags that we don't ever want to miss in life, and also references for treatment. One question that comes up with allergic conjunctivitis is if you are using something, let's say like a Pediatric type of a drop, do you also need to add a Zyrtec orally as well, or is just the drop alone good?
It depends on the person. So some people really have more of a systemic response to the allergen, and their eye symptoms are going to be really well controlled with just the oral Zyrtec. Some people are more eye-only phenotype, and they don't have as much of the systemic, and so they're going to do better with the drop. And most of my patients, I would say I have them on both during the high allergen season for them.
Thank you so much for opening our eyes to all things conjunctivitis. Certainly no pun intended, but that was a wonderful discussion. And thank you to all of you listening out there. And until next time, keep on keeping kids safe out there.